Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi everyone. Thanks everyone for listening to this podcast by the Liver Foundation. I'm Dr. Margaret Ting from National University of Singapore, and I'm really honored and privileged to have with me today Professor Singal. He's very well known in the hepatology community, and he's from the University of Texas Southwestern Medical Center. So thanks a lot, Professor Singal, for joining us today.
Thanks for having me.
Okay, great. So Professor Singal is a renowned authority in the area of hepatocellular carcinoma, or HCC for short, and he has recently written a review that was published in the American Journal of Gastroenterology. This review is titled "Blood-Based Biomarkers for HCC Surveillance: Ready for the Center Stage." So today we'll be just discussing blood-based biomarkers for HCC surveillance a bit in greater detail. So to just kind of establish or start off in terms of HCC surveillance, Professor Singal, what is the importance of HCC surveillance in your opinion?
Yeah, it's a very good question, and something we have to keep in mind that that HCC is the fourth leading cause of cancer-related mortality worldwide, but we know that the prognosis can markedly differ based off multiple factors. But one of the strongest is the stage of the tumor at time of detection. Patients who are found at an early stage have curative therapies available and can achieve survival well over 5, if not 10 years. Whereas those patients who are found at more advanced stages are only typically amenable to palliative therapies, and their median survival is much shorter, typically around 1 to 2, maybe 3 years. And so, early detection is quite critical for HCC for us to have a reasonable prognosis, and therefore professional society guidelines have recommended HCC surveillance among at-risk individuals, largely patients with high risk hepatitis B, or those patients with cirrhosis from any etiology. This practice has been supported by a large randomized control trial that was conducted in China now over 15 to 20 years ago, which showed that HCC surveillance significantly improved early detection and reduced HCC-related mortality by about 37%. In patients with cirrhosis, we don't have a similar randomized trial, but several cohort studies have shown a consistent association between the receipt of HCC surveillance and improved clinical outcomes, including early stage detection, curative therapy receipt, and once again, reduced HCC-related mortality.
And given, as you say, the many benefits of HCC surveillance, what's the general uptake of HCC surveillance in the general population? Do you know any statistics for this?
Yeah, unfortunately, it's not quite where we need to be. So when you take a look at other cancer screening programs, breast cancer, colon cancer, we typically see adherence patterns somewhere around 60 to 70%, with marked improvements over time. HCC screening, I think, is a little bit more complex in terms of, identification of at-risk individuals. The fact that it requires a separate visit to get a radiologic appointment, typically ultrasound. And it has to be done on a semi-annual basis. So it's a little bit more burdensome to patients and providers to do this at regular intervals. When we take a look at literature looking at utilization, most studies across the world have shown that utilization is somewhere between 20 to 30%. And that's consistent between the US, Europe, and Asia, where we see marked underuse of HCC surveillance among at-risk individuals. When we take a look at correlates of surveillance use, surveillance utilization is lower among patients with non-viral etiologies, alcohol and MASLD. And we see it's also lower among patients followed by primary care providers instead of GI or hepatology subspecialists. And so I think it really highlights some of the importance of interventions for us to educate our colleagues outside of GI and hepatology and work through better risk stratification and methods to identify at-risk individuals if we want to hope to increase utilization in the future.
That's a very, very interesting points that you have brought up actually on how, different, depending on the type of provider that the patient is seeing, that might influence their adherence to surveillance, and also in terms of being able to identify whether the patient is even at risk of HCC in the first place. I think that's the key. Now, I just want to shift gears a bit. You mentioned earlier that, most of the society guidelines do recommend ultrasound for HCC surveillance. Maybe you could briefly kind of, summarize what are some of the modalities for HCC surveillance that have been, reported or discussed in literature.
Yeah. So most of the studies in terms of current evaluation focus on imaging. As both you and I have mentioned, ultrasound has been the cornerstone of HCC surveillance for over 20 years now. And so there's a lot of literature that shows that ultrasound-based surveillance can improve these clinical outcomes, like we discussed, in terms of the benefits of surveillance. Although we've also seen increasing literature that shows that, unfortunately, the sensitivity of ultrasound for early stage detection is not quite where we need it to be. And this is particularly true as we shift from viral hepatitis to more and more cases being related to non-viral etiologies. When we take a look at the sensitivity of ultrasound for early stage detection when used alone, the sensitivity of ultrasound is around 47% for finding HCC at an early stage, meaning it misses over half of tumors at an early stage if used alone. We know that ultrasound visualization and sensitivity is lower among patients with obesity and among patients with non-viral liver disease, including alcohol and MASLD. And as you and I know, these are really populations that are increasing in prevalence, which suggests that ultrasound performance will only potentially get worse over time. Now, what can we do today? There have been several studies that show the addition of alpha-fetoprotein, simple serum-based blood biomarker, in combination with ultrasound can improve sensitivity for early stage detection, somewhere around 60 to 65% when the two are used in combination. So although AFP by itself is not a great biomarker, it does appear to be complementary to ultrasound. And so, at least the AASLD and the APASL guidelines have now started to recommend the combination of ultrasound with biomarkers like AFP in terms of optimizing early stage detection today. Now, I think both you and I recognize, and our listeners probably recognize, that 60 to 65% is better than 45%, although not quite where any of us want to be. And so we're really trying to find tests that have higher sensitivity for early stage detection. There have been studies that have come out of largely Korea at this point, but I'm sure we're going to see validation over the next couple of years, looking at cross-sectional imaging. So there's been one study that takes a look at two-phase low-dose CT scan compared to ultrasound. And, this two-phase CT scan, which includes an arterial phase, was shown to have higher sensitivity and specificity than ultrasound. Although I think we need to work out other considerations like access, exposure to radiation if repeated at regular intervals, costs, et cetera, in terms of, cross-sectional imaging being, the answer in the future. Similarly, we've seen a study that looked at MRI versus ultrasound, the PRIUS study, also coming out of Korea, where they conducted both tests concurrently over an 18-month period. And MRI was shown to be superior to ultrasound in terms of early stage detection, as well as specificity compared to ultrasound. But once again, I think we have some issues to work out, like MRI access, capacity, as well as costs. And so, these are interesting research studies, but I think we need to figure out, from a implementation perspective, if these are really answers that could be applied more broadly. The other thing is, at least in terms of MRI is a 45-minute exam. And so it can be quite tough for patients to undergo this at regular intervals. And so from an imaging perspective, there's also been studies that have looked at abbreviated MRIs, taking a look at certain sequences decreasing that MRI exam to about 15 minutes, which can increase throughput, maybe reduce costs. And, at least the studies that exist right now suggest abbreviated MRI can retain high sensitivity and specificity, although we need further validation of this modality as well.
Yeah, so I think you've discussed mainly, as you mentioned earlier, the imaging modalities for HCC surveillance, which include so far ultrasound, and then maybe CT and MRI. But and you also talked a bit about alpha fetoprotein, so that will kind of put us, is the step to discuss the next step of our, discussion on blood-based biomarkers. So that alpha fetoprotein is probably the only established blood-based biomarker that we have so far. And I think in your review article, you also mentioned a couple of other blood-based biomarkers. Could you maybe kind of introduce us to some of these biomarkers, and which one do you think is the most promising so far?
Yeah, no, of course. And so, I think that this is really an exciting area of research. And I think that blood-based biomarkers, in my personal opinion, really are one of the most exciting avenues for surveillance in the future, not only because it offers a potential path to improve test performance, i.e. sensitivity and specificity, but also potentially reduce some of the barriers to surveillance, increasing adherence, and thereby also increasing effectiveness. It doesn't matter how good a test is if it's sitting on your shelf and nobody's using it. And so by making this easier to implement in clinical practice, I think blood-based biomarkers are highly promising in terms of improving effectiveness. Now, you and I have both already mentioned alpha-fetoprotein, as you said nicely, the most validated biomarker that we've seen to date, and the only one that's completed all 5 phases of biomarker validation. There are other promising biomarkers that are also coming around and undergoing further validation. So from a serum-based protein biomarker perspective, one can also look at a couple other biomarkers, including DCP and AFPL3. These biomarkers have been shown to be 2 of the more promising biomarkers when evaluated against a total of 48 biomarkers. These 3, AFP, AFPL3, and DCP, rose to the top in terms of the combination having the best AUC or C statistic in terms of early stage detection. And these 3 biomarkers have been combined into a biomarker panel, including gender and age, called GALAD. And GALAD now has completed phase 2 case control validation in a multi-center, multinational sample set, where it was shown to have sensitivity of 60 to 80% for early stage detection, i.e. competitive to that of ultrasound plus AFP. It also has recently completed cohort evaluation in a retrospective blinded manner, both in the HEADS cohort as well as the Texas HCC consortium cohort. And we see there, once again, it retains high sensitivity for HCC detection, somewhere, once again, around 65% within 3 to 6 months prior to HCC diagnosis. And so once again, appearing to have good test performance in this retrospective cohort study. And so now GALAD is moving forward in terms of a prospective direct comparison of GALAD versus ultrasound plus minus AFP in a head-to-head comparison. And that's called the TRACER study, which is launching in early 2024. And so we'll see if GALAD can outcompete ultrasound plus minus AFP in terms of clinical utility, i.e. early stage detection. Now, in parallel to these protein-based biomarkers, we've also seen a lot of interest in terms of liquid biopsy techniques. Probably the most evaluated to date has been methylated DNA markers, whether this is the Helio liver panel or Oncoguard liver, which has been evaluated by Exact Sciences. These both have been shown to have promising performance in case control studies, superior to that of AFP and competitive to that of GALAD. And those are currently undergoing larger cohort evaluation at this time. And so we'll see what those test performances are when they are done in a cohort manner. But those appear to be at least promising at this time. In terms of earlier evaluation, we've also seen promising performance from other liquid biopsy techniques, like EVs, and also seen this in terms of fragmentomics. So taking a look at variation in the size of the fragments rather than taking a look at specific DNA mutations. And those also have early promising performance in, phase 1 and small phase 2 studies, so case control studies. But once again, I think we need to see data from those types of analyses in larger case control manner before we would consider moving those forward in terms of validation.
So it seems like apart from AFP, GALLOD is probably the next one that may potentially, be completed in terms of having enough evidence to drive its utility. I just wanted to, ask, there are so many biomarkers that are available, and you mentioned that, earlier we also talked about imaging for HCC surveillance. So, in your opinion, what does the future actually look like? What do you think will be the eventual state of HCC surveillance? Do you think that imaging, we will completely never need imaging and we can rely totally on blood-based biomarkers alone? Or do you think that we are heading towards like a combination of perhaps GALLOD plus imaging? What are some of your thoughts on this?
Yeah, it's an interesting question, and obviously, unfortunately, none of us can accurately predict the future. But I'll tell you, my personal sort of quote unquote vision for how I would love to see HCC surveillance is, I think, of course, when you think about this, the easy answer would be like, let's just stack everything on top of each other. Quote unquote, let's go the kitchen sink approach of, let's combine imaging and a couple different biomarkers and sort of, increase the intensity of surveillance to be the highest it can be. And of course, if we did that, we would maximize early stage detection, but we would also maximize patient burden, provider burden, as well as the potential harms of HCC surveillance. And I think, there is a literature now coming around in terms of at least quantifying, the physical harms, i.e., diagnostic evaluation for false positives, the psychological anxiety and distress that can come around from false positive or indeterminate results, and then also the financial distress of patients having to pay for these things, whether that's fully out of pocket or just co-pays and deductibles. And so I think these are considerations when we think of the differential intensity, and I don't think going the kitchen sink is the right approach. What I would love to see is similar to how we've tried to optimize treatment, this precision oncology concept. I would love to see a similar approach for screening, where we come up with a precision screening approach. And, you take each individual patient in front of you and you take a look at their individual risk and you take a look at their individual characteristics and you say, this is the best surveillance strategy for you at this time. So let's take an example here. So in parallel with the imaging studies and the early detection biomarkers that we've talked about, there's also a lot of work being done in terms of clinical risk scores and risk stratification biomarkers, whereby you can take a patient with, let's say, cirrhosis, and you say, look, the quote unquote average risk for a patient with cirrhosis is about 2%. But we can stratify this and identify a low risk group that has an annual risk of HCC of around 0.5%. And we can find a high risk group that has an annual risk of around 5 or 6%. And clearly the surveillance strategies in those two patients should be very different. And it would be not only cost effective, but patient centric if we did a more intensive, let's say in this case, maybe MRI based approach in that high risk individual. And we instead did a low intensity sort of surveillance strategy in that very low risk individual, whether that's repeating the risk stratification assessment in a year or two, or doing something simple like a blood-based biomarker in that low risk patient. So I think that's really where we need to be thinking of as we move forward. And then, you could theoretically overlay even test performance, characteristics on top of that sort of precision screening approach. So, for example, if one were to consider ultrasound in intermediate risk, you could say, look, if you're intermediate risk, but you have non-viral liver disease and obesity, ultrasound's unlikely to work. So you're intermediate risk and we should do, blood-based biomarker. Or you're intermediate risk and you have hepatitis B and you're nice and thin, ultrasound would work very well in you. And so, we would stick with an ultrasound-based approach in that patient. And so by doing this, I think we can come up with, once again, a patient-centric approach. And we're working on modeling this out at this time. And, we've presented this at an annual meeting in the process of writing this up, but we've at least demonstrated that this approach would not only, once again, optimize early detection, but would be highly cost-effective compared to our current approach of one size fits all.
So this is very, very interesting. And I think just to kind of summarize what you said, I think you mentioned that HCC surveillance and screening should be kind of individualized and depends on the risk profile of the patient in terms of their risk for HCC and I guess their etiology of liver disease. But that's just one part of the equation. The other part would be what type of surveillance they would receive, right? And then that would also depend then again on their individual patient characteristics. You mentioned something very interesting because I also wanted to ask, which I forgot to earlier, does the etiology of liver disease, whether it's a non-viral, like viral, non-viral, like whether it's alcoholic and metabolic or metabolic, does that affect the test performance of blood-based biomarkers?
Yeah. So, when we think of blood-based biomarkers, once again, historically for alpha-fetoprotein, we do know that etiology impacted AFP performance. Viral etiology by itself could cause, a high sort of inflammatory background in the liver and thereby cause elevated AFP levels at baseline. And so AFP was shown to have higher sensitivity in viral etiologies, but also lower specificity. So when you take a look at non-viral etiologies, AFP, the performance characteristics are converse, where it has lower sensitivity at the typical threshold of 20 nanograms per milliliter, but higher specificity. And so there's been some studies that suggest in non-viral etiologies, actually for AFP, we should be using a lower threshold, somewhere around 8 to 11 nanograms per milliliter in alcohol and mast-related liver disease. But going back to your question outside of AFP, when you take a look at, these emerging biomarkers, AFPL3, DCP, liquid biopsy techniques, the early data suggests fairly consistent performance across etiologies. And so, it's thought that the biomarkers that we are actually most interested in terms of emerging, coming and being validated at this time, these appear to be consistent across etiologies, but we'll have to see, in larger studies.
Oh, that's good to hear. Just one final question on HCC surveillance, perhaps a bit broader question. I mean, we've talked a lot about, the blood-based biomarkers, imaging, and, what you think the future will look like. So what do you think are some of the other barriers to improving adherence to HCC surveillance and how, as physicians and providers, can we help to overcome some of these barriers?
Yeah, so there have been studies that have looked at patient and provider reported barriers to surveillance. When you take a look at patients, the most common barriers that patients report include things like transportation, uncertainty, where to get an ultrasound done, costs of getting this done. And so, it sounds like many of those barriers are actually specific to getting a separate imaging study on a separate day. And so, that goes back to my prior comment where theoretically shifting to a blood-based approach where you can get that done, via the lab the same day as a clinic visit will address many of these patient barriers and potentially, once again, increase adherence. When you take a look at providers, we already talked about the differences in terms of utilization between primary care, providers and gastroenterologists or hepatologists. And so survey studies among primary care providers identify a few different barriers, but the most notable, I think, is one that is familiar to many practicing providers, is being asked to do more and more in less time. And so it's really competing demands in clinic and shorter times to see the number of patients we want to see. So, this is a harder barrier, I would argue, to overcome, but can be overcome by, sort of strategies where this is either automated through recall systems, reminder systems, and electronic medical records, or we've evaluated outreach strategies where you do this on a population health basis. And I know, in Asia, this has actually been done very well in terms of these, population health strategies where you can even do community sort of cancer screening or, community health fairs. And I think that's really one of the approaches that we will need to take in terms of thinking through health systems caring for the broader patients and thinking through these, outreach strategies.
So I guess in summary, taking into account everything we discussed in this short time, I guess what the message we are both trying to kind of bring forward is that HCC surveillance is important, and surveillance is something that should be patient kind of individualized to the patient. Is there anything else that you would like to add on to this discussion, or any final comments that you want to make on this topic?
Yeah, I think it's really, once again, it's important, not only the concepts that we've already discussed, but it's also important to remember that surveillance is one step in the cancer care continuum. And so, obviously it's important to perform surveillance to find HCC at an early stage, but unfortunately that's not the only failure in the cancer care delivery process that we see. And so when you find patients at an early stage, it's important to follow this up with, the right diagnostic imaging. It's then important to refer them for multidisciplinary treatment so they can be considered for curative therapies. And so surveillance improves survival by facilitating curative therapy receipt. And so, like, if all roads lead to embolic or systemic therapies, it actually doesn't improve survival. It just gives you lead time and length time bias. And so I think it's really important for these patients that are found early to be referred to expert centers with multidisciplinary care so we can really increase the proportion of patients undergoing curative surgical therapies.
Okay, so thanks a lot, Professor Singal, for your time, and thanks everyone else for listening in to this podcast by the Liver Foundation.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.